Specialty Story, session number 124. Whether you're a pre-med or a medical student, you've answered the calling to become a physician. Soon you'll have to start deciding what type of medicine you'll want to practice. This podcast will tell you the stories of specialists from every field to give you the information to make sure you make the most informed decision possible when it comes to choosing your specialty. Welcome to Specialty Stories. Thank you so much for taking the time to join us today. This week, I have a great guest, a cytopathologist who talks about her journey to cytopathology, switching into pathology, kind of her third and fourth year of medical school, realizing that the path that she was on wasn't right for her. This week, we have Dr. Elizabeth Morency on the podcast to talk about cytopathology and much more. We start the conversation by talking about how Dr. Morency got interested in pathology to begin with.
So I always kind of knew I was interested in medicine because my dad was actually a family physician. And so I went into med school actually thinking that that's what I wanted to do. And it actually wasn't until towards the end of my third and fourth year that I kind of realized I wasn't as interested in clinical medicine as I thought I would be as far as a career for the rest of my professional life. And I remembered first year of medical school, a histology lecture that was given by one of the pathologists, and thinking it was really cool and never having heard about it and wanting to kind of maybe explore that a little bit more. So I did a couple electives in my fourth year and I absolutely fell in love with it. So it was kind of accidental, kind of later on in the game. But I feel like a lot of people that go into path usually have that track. It's pretty rare that somebody is like a child of a pathologist or just has knowledge of pathology before they go into medicine.
Yeah.
So it was I would say my first fourth year elective in pathology that I really thought it was fascinating, being able to kind of be behind the scenes and see where these diagnoses are coming from and how you work through the material that you get to come to a final answer.
What was it about that rotation and what you were seeing and doing that was oh, this really floats my boat?
I've always been somebody who's really into puzzles and really analytical. And I always want to know, I'm nosy, I guess you could say. And I always want to know what the final answer is. And I just remember being, on the wards as part of the clinical team, sort of waiting on pathology to figure out what to do next. So I was always kind of what exactly are these guys doing? Why can't we figure out what's going on? So it was kind of curiosity that led me to explore that side of it. And then I was I want to be on that side. I want to be the one with the answers and sort of not running the show, but helping to direct what the next steps are instead of sort of sitting back and waiting. And to a large degree, not really understanding where it's coming from. And to this day, a lot of clinical physicians kind of just think it's somewhat of a black box, because they have a lot going on. I'm not saying it's willful ignorance, but they just don't know what exactly it is that we do. And they just trust, they did their training. They're going to say that it's cancer. They're going to say it's benign. They're going to say it's infectious. And we're going to go from there, move on without really knowing exactly the ins and outs. And I just thought the ins and outs were the most interesting thing that I had experienced in medical school. And I was I think I want to focus my career in this sort of more diagnostic realm.
Yeah. So you came in thinking more medicine, something more medically related, based
Primary
on
care,
based on the experience with your father. For someone who is also going through this process, thinking that, but having doubts in their mind, what were some of the things for you that really triggered it to go, this isn't what I need and want. I need to go looking for something else?
I think, I did internal medicine, I did family medicine, and I enjoyed the rotations, but I realized that there's a huge difference between shadowing your dad. And I had a really good experience with my pediatrician. So shadowing your pediatrician and then also being the person versus being the person who has that primary responsibility and is taking care of this patient, with this healthcare team. And I just couldn't see myself doing it day in, day out, because I feel like a lot of clinical medicine, there's only so much that you can control. A lot of it also has to deal with patient compliance and, making sure that they follow up with the recommendations that you give, whether it be, taking your medication or physical therapy or cessation of smoking, et cetera, et cetera. And I just didn't have the patience, even as a third year medical student, just experiencing this sort of clinical care role with patients who just didn't do it like the first time or the second time. And I realized it really takes a special human being. And I always idolize my dad. I forever will, but I gained even a new level of like respect and like appreciation for what he did. He was a family physician for 25 years. And I was like, I couldn't even last 6 weeks. So I just realized my personality also is a little bit unique, because most people who go into medicine, go into clinical medicine. And so I feel like those of us who find that it's not quite working out for us, we just like to be in control. We like to know exactly what's going on. We want to have ownership of our cases from start to finish. And, there's not really any other discipline in medicine that allows you to do that like pathology does. So I was kind of lucky to find that, because I was kind of between, graduating and doing something else medicine adjacent, or I was also considering radiology, because again, you're sort of like more on the diagnostic side and your communication is more with other physicians who will listen to what you say, as opposed to patients who maybe think they know better or, promise you that they're going to stop eating McDonald's every day, but then, you discharge them and then they're back within a week. So just a combination of my personality and just seeing the realities of some of the challenges of primary care and realizing it just wasn't going to be a good fit for me.
Yeah. What traits do you think lead to someone being a good pathologist?
Sure. Somebody who's very curious, very inquisitive, asks a lot of questions. Like I said, I say it like jokingly, but like nosy, like you want to know exactly what's going on. Very detail oriented. I mean, a lot of times, especially in cytopathology, maybe even to a higher degree than surgical pathology, so you can sometimes hang a diagnosis on a single cell, and a slide can have thousands of cells on it. So somebody who's very methodical and, just almost, I don't want to say anal retentive, because I feel like that has a negative connotation, but sort of, has those sort of qualities to them. Somebody who's really good at communication. And I think that's something that's not commonly attributed to pathologists, because people frequently see us as behind the scenes, not antisocial, kind of just all about our slides and specimens. But at the end of the day, if we're not able to communicate to our clinical colleagues what exactly our impressions are, what the final diagnosis is, in cases where we don't know necessarily the final diagnosis, but what our differential is and why we're ordering, this particular diagnosis higher than this one, and also follow up things that we think that they can do that would help us, whether it be a repeat biopsy or just, continue to watch this person. We're not that worried. So strong communication skills, I think, are really important. And just being able to work in an interdisciplinary team, it kind of goes hand in hand with communication. A lot of times you're working with surgeons, you're working with nurse practitioners, you're working with medical assistants, you're working with medical students. So being able to be comfortable in that setting and to help make sure that you're getting your message across clearly, depending on what particular setting that you're in.
What are some of the biggest myths or misconceptions around the field of pathology that you have to debunk all the time?
Sure. Yeah. I was guilty of some myself. I mean, I think the biggest one is that, if you want to do pathology, it's like you're basically a forensic pathologist, like you're CSI. I mean, to this day, when people ask me what I do, they're like, oh, so you like hang out with dead people and you do autopsies all the time. And it's like, actually, that's one big part. And that's what our forensic pathologists do. And they do specialized fellowship training and are boarded, and that's what their role is. But that's one small part of the entire scope of what we call anatomic pathology. And so there's a lot more than that. We work in the hospital. We work alongside surgeons and, gastroenterologists and pulmonary critical care docs. And it's really exciting. I think people think it's boring because we don't get to see patients. And while I always enjoyed seeing patients, and that's probably one of the things and one of the most common things you'll hear about pathologists, what they maybe miss from their, general medical education days. It's really exciting. It's really cool, not only being able to diagnose, what this shadowy lung mass is, but to even take it further in the era of, molecular diagnostics and sequencing genes and precision medicine, being able to tell the oncologists not only prognostic indicators like, oh, this patient, has a good mutation versus, a mutation with a poor, disease-free survival or progression-free survival. But also they're going to respond to this chemotherapeutic agent as opposed to that chemotherapeutic agent. So saving this patient who, depending on what they have, wasted time and potentially adding time to their life because of what it is that we do. Another thing is, I kind of alluded to it before, that we're like antisocial. Like, oh, you went into pathology because you don't like to talk to people. You can't make eye contact. You're really shy. I think there are some people who maybe go into pathology because they do feel more comfortable behind the scenes. But I can, speak for my department and say that we're very social. We're very involved with the medical school. We're very involved with our clinical colleagues. Within the department itself, we have a very strong social sort of atmosphere, if you will, whether it's like potlucks at certain attendings' houses, or, we went and did a paint and sip the other day with some of the residents as part of the sort of ACGME wellness thing. But it's like, we do this stuff anyway. So sure, we can say that we did this as part of, the wellness, whatever mandate. But I think those are some of the things that were like boring and quiet and just kind of like shoved in the corner. But that's not at all the case.
Yeah. Okay. So as a cytopathologist, right, you're board certified in cytopathology. What are you doing, diagnosing? What are the team coming for you or to you with what questions, with what kind of specimens and stuff like that?
Sure. So general sort of anatomic pathology, you tend to think about surgical pathology, where you actually get pieces of tissue and you're looking at whole sections of, let's say somebody has like a breast mass. The surgeon will excise the breast mass or even do a core biopsy, and you can actually look at the architecture of the tumor and sort of get a whole two-dimensional slice of the lesion that you're looking at. Whereas cytopathology, we're literally dealing with cells. So same patient, as opposed to a core biopsy, and we don't do this as much anymore, but you stick a fine needle in and you actually just aspirate the cells. So we can't tell you if it's necessarily, infiltrating, and we can't tell you what the architecture looks like, but we can say, hey, these cells are really ugly. This is probably cancer, or these cells are super bland. It's probably just a benign neoplasm. Another big part of cytopathology is looking at gyne specimens, so pap smears. So a large volume of our material are pap smears from OB-GYN. We also get all of the fluids. So peritoneal tap. So let's say a patient who's end-stage cirrhosis, who has large volume ascites or fluid in their abdominal cavity. The medical team will stick, a needle in, do a paracentesis or a tap, take out all the fluid. And it's kind of, depending on the scenario, sometimes they'll do serial taps and it's more therapeutic than diagnostic, but they'll usually still send us a sample of the fluid. And we just basically look to make sure there isn't anything infectious going on or anything neoplastic, like if there's a concern for, liver cell cancer or some other primary somewhere that might be causing this abnormal accumulation of fluid in the belly. And then the third part, so it's like kind of three main parts. So it's like gynes, pap smears, fluids, whether it's from the lung, the abdominal or pelvic cavity, and then sort of deep biopsies. So we do superficial aspirations of like palpable lesions, usually, in the skin and soft tissue, and then head and neck. So some places here, we pretty much defer to interventional radiology. But where I did my fellowship, we actually did a fair number of thyroid aspirations ourselves with and without ultrasound guidance. We actually have a clinic here that our fellows participate in where they have the opportunity to do FNAs themselves of salivary gland and sort of head and neck lesions. And then the deep biopsies are things like the person has a pancreatic mass. Like, do we think it's cancer? So the gastroenterologist will go in and do the biopsy, and then they'll send us the sample and we'll make the diagnosis. So those are sort of the three major categories, but it's a lot of sort of squirting cells on slides and making the diagnosis from there.
But in some places, it sounds like you can go out and interact with the patients and actually do the biopsies yourself.
Absolutely.
That's awesome.
And I love being able to do that because, I do miss that aspect of medicine and being able to see, the patient themselves and take the history and literally put your hands on the lesion of concern and then be able to tell them within a matter of minutes what our preliminary impression is. There's no other specialty that can really do that. So I think that's something that's really cool about cyto. However, like I said, a lot of that has been taken over by interventional radiology.
Yep.
But depending on where you are, and I feel like at a lot of sort of non-academic or outside sort of community practices, the cytopathologist will FNA like everything. And they have ultrasound guidance training. So they can they won't do something that requires, like heavy sedation or like a really deep biopsy. We defer, to the specialists for that because they are associated with, relatively high potential complications. But sort of superficial and like intermediate deep biopsies, we are trained to do that as part of our fellowship training. So
awesome.
We do every now and again get to see patients too.
What does a typical day look like for you?
So it depends kind of on what service I'm on. But usually in academics, I try and come in the morning and let's say I'm on fluids. So I'm on non-gyne fluids. So these are the specimens that come from like a patient who, let's say, has a history of lung cancer, and now they have a pleural effusion or an abnormal collection of fluid around the lungs. And the clinical team has aspirated the fluid, and basically we get a series of slides from specimens like that. And so if I'm teaching, I'll usually come in and do a didactic lecture. And so we kind of break it down by organ system. So one day somebody will be talking about breast cytology, another day you'll be talking about benign lung, so on and so forth. And then the residents have the opportunity and fellows to preview the cases that are coming out for the day. And so usually I'm just sort of catching up on emails or working on other projects. And then we sit together with the resident and kind of go over the cases. And so depending on their level of training, some have looked up everything, have written their impression, and it's like, okay, I agree, next case. Others, it's their very first time on cyto. So it's like, okay, this is a mesothelial cell, like just the basics of like identifying what it is that they're looking at. Kind of do that throughout the day. There's always different lectures and conferences, but usually we're finished as far as sitting with the trainee around early afternoon. And depending on how thoroughly you went over the cases, you can sometimes just release them at that point, just officially sign them out and send them out to the clinicians. Other times, if you kind of went through quickly with a more senior resident, you kind of given the slides another quick look and sign them out. But depending on, if it's like a moderately heavy day or kind of a typically heavy day, you're pretty much done with sign out around like, I'd say 3-4 o'clock. And then the rest of the afternoon, again, we're all very involved in, medical school teaching, mentoring, all of the different committees in the hospital are going to be, are going to have people from pathology who are members. So things like the quality committee, education committee. So just preparing for, those meetings and lectures and different things. But I think that's like pretty much what a typical day is.
Why did you decide to stay in academics versus going out to the community?
Sure. I actually did not plan to do that. I was trained really well, though, in obviously two pretty highly regarded academic institutions. And at both places, at some of the attendings I work with who became mentors, who I still am very close with to this day, were like, no, you're too good of a teacher. I think there's like this fear and this like insecurity, like, oh, do I really know enough to like teach other people that I had, and then a lot of junior faculty going into academics kind of like struggle with. But thanks to, the experience that I had getting to teach as a fellow, like teaching residents and working on projects with other academic pathologists, I felt like it would be a shame to not at least give it a try, not to talk myself out of it before I even saw what it was really like. And it was that coupled with the fact that I came to Chicago to do my last fellowship, and I absolutely fell in love with the city. And it was kind of like only academic spots were open. So I was like, if I'm going to do it, I'm going to do it now. And I really want to do it here. And there was a close sort of back and forth and a lot of communication, consults, everything between where I did my fellowship and Northwestern. And so, I applied, I interviewed, and I absolutely fell in love with the department. Like, it just wasn't, from the other side, it wasn't as scary as I thought it was going to be. And I realized like, I do have something to share. I do feel like I can contribute, and I'm not just like sort of sneaking in the back door. And it's been great. I do love teaching. I think that's sort of the foundation of academic medicine. Obviously, you want to be productive. You want to publish and be involved in projects. You want to be in medical education. But day to day, you have the opportunity to teach residents and fellows and medical students, which is probably one of my favorite things, because I never want a medical student who's potentially interested in pathology to not have real exposure to it until their third or fourth year, like I did. Obviously, it turned out fine. And the nature of pathology still is that, you don't need to have like a million publications or, all of your electives done before you submit your ERAS applications, although it might be a little bit different now. But it's still nice to know earlier on than later that this might be something that I would want to do. So, the combination of those things got me in, and just really enjoying it has kept me here to this point.
Do you think you have enough time for life outside of the hospital?
I absolutely do. And I think that, and not to say that we're not really busy, because we are super busy, especially for pathology. I mean, depending on where you're at, pathology can be a pretty 8 to 5 sort of weekends, mostly free type of place. That's not necessarily the case at the bigger academic institutions, but there's still, at least, and I can only speak for myself, plenty of time to have a life outside of the hospital and outside of your clinical and academic responsibilities. And I think that's a big part of the reason why I wanted to stay in Chicago, because it's such a great town to live in, as especially somebody who wasn't from here, and it was all completely brand new to me. So I absolutely think that path is a great lifestyle field as well.
What does the training path look like to become a cytopathologist?
Sure. So you do 4 years of general anatomic and clinical pathology. Although I feel like that's pretty much what you want to do, APCP. You could theoretically just do AP only, which is 3 years, but that's generally not encouraged, because if you do go into community practice or private practice, they're going to want you to have that clinical pathology training. So it's more like lab medicine stuff, like microbiology, clinical chemistry, blood bank. Do I use any of that now? No. But if I were to go out into the community, am I glad that I had it? Yes. So typical route is 4 years APCP, and then it's 1 year of cytopathology. And then you sit for the boards, and then you practice.
What does residency look like? A lot of students are dreading residency with how hard it is and how
Right.
Much lack of sleep there is. Is pathology maybe a little bit easier, a little bit harder? What does that look like?
Yeah, I think pathology is definitely a little bit easier than, the sort of standard internal medicine, or at the farther end, like surgery. You still have, a good amount of time to sleep. For the most part, your call is at home. That said, it is super challenging, because you just don't get any or very little pathology exposure or training in medical school. So the amount of material you have to learn is just, it's huge. It's kind of like you're starting completely blind. So that's a little bit intimidating, but I feel like most pathologists in general are pretty easygoing people. Every now and again, you might have somebody who's a little bit more of a, old school and will be like, oh, why did you gross this way or whatever, and make you a little bit more nervous at the time of sign out. But it's not too bad. It's rigorous in the sense that the learning curve is just super steep. But once I feel like I started to feel really comfortable by around second year. You've done a couple of surge path rotations, so you know how to gross the majority of sort of bread and butter specimens, and then also sign them out. You've done an autopsy rotation or two, so you feel somewhat comfortable with that. So then by second year, you can start to think about, okay, what am I interested in as far as subspecialties? And then based on that, okay, I want to work on projects. And let's say you're interested in gynecologic pathology. So I want to look at uterine cancer, ovarian cancer, or I like GI. So I want to look at, those types of specialties. And then, third and fourth year, you get a little bit more responsibility. I can speak to the experience here at Northwestern. You're sort of considered a senior resident at third year. So then you kind of take on some of the responsibilities of helping to onboard and orient the first year residents while continuing to work on your projects and building your CV. You're also interviewing for fellowship because now, just because of the way that it is, fellowships tend to fill 2 years out. So you kind of have to know by the end of second year what you're interested in, which is kind of unfortunate because you've only had 2 years exposure, but that's just sort of the nature of the beast. We are in that sort of scenario in cytopathology here at Northwestern. We're going to be interviewing for I don't even remember now. I think it's 2022, 23 the next time around, because we've already filled for the next 2 years. And then once you have that done, fourth year is pretty much studying for the boards. Path boards are probably one of the most challenging of all specialties just because of the breadth of information, especially if you're doing anatomic and clinical. But I feel like a lot of programs are really good about making sure you have your heavier rotations earlier on so that you can do lighter rotations and even just have dedicated study time to take your boards. And then that's kind of
for the osteopathic medical student listening to this, do you see any negative bias towards the DOs who want to be cytopathologists?
Not at all. Not at all. In fact, we have one of our in-house residents who's a DO student is going to be a cytopathology fellow in 2 years. And he's great and we love him. So there's definitely no negative perception of DOs or like Caribbean or whatever.
Good.
Sort of alternative pathways.
What do you wish the primary care providers knew about what you're doing day in and day out as a cytopathologist to help you with your job?
Yes, to all of my clinical friends listening. Like, how much time do we have? I think the most important thing, and we've been somewhat spoiled because our clinicians are pretty savvy here, but that's definitely sort of the exception, not the rule. Just to have an understanding of the concept of turnaround time. So like if you do a biopsy on Tuesday, because of the nature of grossing the specimens, it's basically describing the specimen, embedding it in paraffin and cutting it, just the whole processing period. The slide isn't going to come out until Thursday or whatever your lab TAT process is at your institution. And so it's like, don't start calling, don't start paging, don't start emailing, don't schedule your patients too prematurely and say, oh, okay, I understand it's not coming out, but we have the patient in clinic right now. So just educate yourself on just the basics of the turnaround time for a biopsy, which is usually 2 to 3 days, and a major surgical resection specimen. So going back to breast. So like a breast biopsy, again, if it's done on Tuesday, it'll probably be finalized unless we have to do any sort of additional immunohistochemical stains or fish or whatever Thursday. And then if you do a mastectomy or a lumpectomy, it's like a week. So that's helpful. I think having an understanding of what we mean when we say we need to do additional studies. So let's say it's a breast biopsy and we're concerned for potential invasive cancer, but it's not obvious. And we have to do something called an immunostain that can show either the presence or absence of sort of the protective lining cells that keep sort of incipient carcinoma or cancer from being invasive. If they're gone, then we can make that call and call it, minimally invasive cancer. Or if they're still present, we can say, it's confined, it's still in situ carcinoma, but that takes an extra day. So just having an understanding of that. Again, these are things that we use like pretty frequently, but we still will get the calls from either the radiologist who did the biopsy or the oncologist who's seeing the patient after the fact. So that would be really helpful. To our surgeon friends, an understanding of how frozen section works. So frozen section or intraoperative consultation is when you're evaluating something with the patient on the table. And usually it's a margin, or it's a question of what is this tumor? Like how aggressive is it? How big of a margin do I have to put around it? Again, we can't just lay hands on the tissue and say what it is. We get the tissue, we process it, we get a slide. We have a 20-minute window to do this. So it's like, don't start calling before the 20 minutes. And if you send us 5 margins at the same time, you have to understand that we may need more than that 5 minutes. So just the basic pathology, like processing and understanding that when we say we need more time, it's not because we're trying to hide the diagnosis or keep it away from you. It's because, our responsibility at the end of the day is to the patient. So we're never going to feel, and some people do, unfortunately, but I personally, and I try to tell my residents and my colleagues, don't feel pushed or bullied to make a bad call or a premature call because you've got somebody leaning on you because you don't feel like you have enough time to do that extra stain that would make you go from maybe 90% sure to 100% sure. So to just be understanding of what we do, have just a basic intro level, like 101 level understanding what pathology is, and to just work with us, I think, and to communicate. Let us know, okay, the patient is coming in. There are certain things that we can sometimes do to move the process along. We can prioritize things, but to try not to put us in a position where we're rushing, because pathology is very challenging inherently. And so it's like, you don't want to put any additional weight or like pressure on us that might make us, miss something or overcall something. So I think that's sort of the majority of what I would want to share.
What would you go back and tell your pre-pathology self about pathology and cytopathology and where you are now?
Oh, that's an interesting question. There were definitely times where I, especially early on in residency, kind of second guessed pathology. And I was like, I went to medical school to take care of patients. And now I'm wondering if I really made the right decision. And to just say, to believe in yourself, to work hard, read more. That's probably one thing that I didn't do. And I still am working on incorporating into my like daily life, just, keeping up on the literature and just the importance of having a great clinical history, having knowing the radiology and just being super prepared. I mean, I can remember some of the sign outs where I kind of showed up and I just did not have all my stuff together and just feeling really bad. And now being an attending and sometimes having the same thing happen, just impressing upon the resident or fellow how important it is to be prepared, to know about the case that you're dealing with, as far as, the recent literature. And also, if it's something complicated, if there's something in the neck, where exactly in the neck is it coming from? Did you look at the radiology? Did you look at the ENT note? Have you talked to the clinicians? I mean, we have a great sort of open communication between a lot of our clinicians. So just stick with it. Always, don't be afraid to ask questions. I think something that I actually work with a group of medical students, and one of their biggest things is I don't want to annoy my preceptor. I don't want to annoy my attending. I don't want to annoy, the person I'm signing out with. And it's like, it's not. The more questions you ask, the better. So, don't be afraid to be quote unquote annoying, because that's what we're here for. We're here to teach you. We're here to like answer your questions, because a lot of times you help us.
Yeah.
We miss things. And so I'll have a resident ask something like, we'll be sending out a kidney, like I'm on GU, we have a nephrectomy specimen and they'll say, oh, I didn't notice an adrenal. Because depending on the surgery, if they do a total nephrectomy or radical nephrectomy, sometimes they take the adrenal or leave it. And it's like, oh, yeah. No, I had looked at the note and they didn't. And I actually didn't. So I was like, but let's just like look at the op note. And they did, in fact, save the adrenal. So they just took the kidney. And I was like, yeah, that's what I thought. But it's like I completely could have potentially signed it out. No mention of the adrenal. It's like still in the bucket or something, which is a huge, huge deal.
Yep.
So don't be afraid. That's what we're here for. Questions. There's no dumb questions really in pathology and in medicine. There really are. So,
yeah. I would maybe add a small little asterisk to that, because I hear this a lot from other attendings too, is we seem to be in a culture where, because Google is at our fingertips, a lot of people aren't using our resources, and they're like, oh, the attending's right there, let me just ask this question, when you could have done a little bit of research before and then say, hey, whatever, I was reading about this and I still have a question about that, right? And then it's like, okay, come informed, and then let me know that you've put in some work so that you're just not being lazy.
100%. I like that little caveat. Like, show me that you've taken some initiative. And a lot of times you're teaching me something. Like, I haven't read every article. So it's like, oh, there was a new thing in AJSP. Like, fantastic. Now I'll go and reference it myself, because that can affect my clinical practice. Yeah. So no, I really like that point that you made.
What do you like the most about being a cytopathologist?
Oh my goodness. I mean, so we're the fastest as far as coming to a diagnosis of anybody. So even within the realm of pathology, and sometimes that bites us in the butt, but when we work with the interventional radiologist, which is probably one of my favorite things about cytopathology, we can literally give a diagnosis on anything within minutes, because what we do is a lot of times we go down to make sure the specimen is adequate. In fact, we call it adequacies. So let's say there's a patient with a lung mass, and they want to know A, what it is, and then B, how we best triage a material. Because a lot of times they can't get a ton of tissue, so they want to make sure that it's going to the right place. And so we can tell, the clinician, who a lot of times will page us, they'll say, hey, we have a patient we're sending down. We're concerned about small cell. We're concerned about lymphoma. We're concerned about primary versus metastatic cancer. Could you give us a prelim? And it's like, we actually can. And it's great when, it's a slam dunk. They have a history of colon. It looks like colon. It's colon. We're done. Not so great when we're like, it's really ugly. It's tumor, but I can't tell you any more than that. But even then, it's like, at least we know we have diagnostic material. We can send this for next gen sequencing, see if they can be eligible for a trial. We're going to make sure we have enough tissue to do immunostains to see if it's lung primary or if it's coming from somewhere else. We can send it to heme and put some in flow cytometry to send, for those markers. So I like having all the answers, and we don't always have all the answers, but I like being in a position to potentially get things moving that much quicker than, having to wait for that like extra processing day or that sort of thing. And then in the instances, because, they don't always listen, where the surgeon or whoever schedules the patient, sometimes it's even in the most like insane cases for like surgical resection, like 2 days after the biopsy, being able to actually say, okay, this is what it is. This is probably the surgery you should do. Although there are instances where it's like, we're going to need more time. You're going to have to cancel the surgery and like push it back. So being able to just kind of be on the ball and give that information. I was always interested in women's health. And I love that, looking at gyne and doing projects with the OB-GYNs and just trying to improve screening adherence, improve patient education, improve the synergy of, high-risk HPV testing, which is a molecular test, with our sort of diagnostic under the slide sort of testing. Feeling like I'm helping to make a difference in that realm, even though it's not on the clinical side, it's more on the sort of research and diagnostic side, I think is pretty cool. I don't know. And I like that it just in pathology in general, we get to, I mean, you really are the doctor's doctor. And I like, getting to have those relationships with, the ENT surgeons, the interventional radiologists, the gastroenterologists, the pulmonologists. It's just a really cool position to be in because they kind of look to you for the final answer. And you're kind of like, yeah, that's right. Respect what I do. So I feel very lucky that I found it, and I'm really happy. And it's constantly changing. I talked about how the boards are so challenging because every day there's like a new entity being described or a new diagnostic study. And now with, precision medicine, we're literally sequencing things down to one like point mutation. So it's just, there's always more to learn. I mean, that goes for medicine as a whole, but I feel like in pathology, it's even more heightened and more significant. And you're just never bored. You're never like, okay, I've finished all the books. I've read all the articles. There's just always something new to learn about. And there's always something new to investigate. Yeah. So I think that's pretty cool.
And yet here we are with medical school crunching down our 2 years into 16 months. And it's just crazy.
It's insane.
Yeah. So let's talk about technology for a second, because I think with pathology and radiology are the two biggest fields where technology is trying to come in and help and change a lot of things. I know Google has a huge initiative using kind of their visual recognition algorithms to go, oh, look, in this picture of a slide, I see these 10 cells that they can spot 10 cells in a split second that would have taken you a couple minutes to look through a whole slide. Do you feel like this technology coming in is going to help you diagnose better, diagnose more accurately, diagnose faster, or is there potential where this is going to take over the world?
So it's so funny and so timely that you asked this question, because we actually had a guy who trained at Google whose background is informatics come in, and I think we're going to hire him. Because that's just the wave and the direction that we're going. And at one point in his lecture, which was fascinating, he said, okay, raise your hands if you think, we're coming for your job. And I was like, me, half kidding, because they showed us, what these programs can do. Mm-hmm. And, but then he talked me off the ledge and showed how, at the end of that, you still need, a human, you still need pathologists, you still need people with those 4, 5, 6 years of training. Yep. And it really is a helpful diagnostic adjunct. It's there to help us be more efficient. It's there to make sure that we don't miss these, micro metastases. I mean, I feel like that's the classic example. So a patient with a history of breast cancer, lobular, which is a particularly sneaky, insidious type of tumor because it likes to spread as single individual cells that we sometimes miss. Especially on frozen. So when the surgeon is trying to decide intraoperatively, do I need to take out a bunch of lymph nodes under this person's arm, which is associated with a lot of post-operative sort of potential complications, or is this tumor still, as far as we know, confined, to the breast? And it's amazing what it can do. I mean, it can really find cells to a resolution better than our eyes ever could. So it really is just, technology there to make us better and faster and more effective at what we do. So I'm not that scared. And I think I still have enough time. So where I'm at in the stage of my career, I don't have to worry about being replaced by the machines for a while.
If you had to do it all over again, would you still be a cytopathologist?
117,000%. Without a doubt. And it's interesting though, because I did not necessarily plan on cytopathology as a second fellowship. My original plan was, when I was still thinking I wanted to do sort of community, non-academic practice, was to do the one surgical pathology fellowship that I did and then look for jobs. And again, it was just sort of the nature of the market. The market wasn't great. And I knew that I wanted to be in a big city, and those were the places that were the most saturated. And I saw that a lot of the open jobs wanted another subspecialty training. And I happened to and actually did some research projects as a resident in cytopathology. And so I was like, okay, I could definitely see myself doing, that one more year of training, and that would just make me so much more marketable regardless of whether I decide to go private or academic. And so I'm so grateful that I didn't find this like perfect job at that time, because I would not be here. And so it all kind of worked out. And that's just kind of how it works. I get asked all the time by students who do want to go into pathology, residents who are starting to think about fellowships and jobs, and what does it look like? Am I going to find a job? And it's like, depending on where they are, I'm like, you're 4 years, 5 years out, things could be vastly different from where they are now. So just do your training, do your projects, put yourself in the best possible position you could be, so that when you are ready to start looking, you don't have any regrets. Like, oh, I wish I had done this, or I wish I had, skipped this. Like, you'll never doing an extra fellowship. I mean, we kind of not look down on, but people kind of scratch their heads if you do more than like 2 fellowships. But you never want to sort of cut out one because you're like, I need to jump in the market earlier, because you can regret not having that extra certification that would make you even a more appealing candidate across a broader sort of scope. So I would not change a single thing.
What final words of wisdom would you have for the medical student or even pre-med student listening to this, thinking about pathology or cytopathology?
I would say, don't believe the sort of preconceived notions that, we're scary people and we don't like, anyone to visit us. Like, I love nothing more than, and we actually have a pre-medical intern program here at Northwestern where we have college kids come who think that they're interested in pathology. And it's the coolest thing ever, because I forget where they are in their training. And I'm like saying all these things and they're like, wait, what? Go back to college days. And it's like, oh, okay. But seek out people, who are in the field and ask questions. And this goes for any specialty. I have students who are interested in ENT, and they're like, oh, well, I've heard of this one guy, but I'm afraid to approach him. Like, that's what we're here for. In an academic institution, we are mentors to everyone. Like, we're potential mentors to everyone. And, if someone's busy, they're busy, and they say they're busy, and okay, it's fine. It's not a personal attack. And I get it. It's scary. I was scared as a resident to ask attendings to work on projects with me. So it's asking a lot of, a college student or a very early medical student to just waltz into, surgery or pathology or anesthesia. But, while I can't speak to them, I will say pathologists, for the most part, are very friendly. We're laid back people. We're always looking for ways to sort of educate, early medical trainees as to what it is that we do. Even if you don't necessarily go into pathology, it benefits everyone, from the patient to the clinician to the pathologist working on the case, that the clinician is educated as to what exactly is happening with their specimen, and what the timetable is and why it's this many days. So read up on it if you don't feel quite ready to take that step, if you're not in a position to necessarily, you don't live by an academic institution or whatever, go online. There's a lot of great resources. There's CAP, the College of American Pathology. There's ASCP, the American Society of Clinical Pathology. You can just Google pathology just so you have an idea of what it really is outside of, CSI, or, some people think I do speech pathology, like just to give yourself a basic understanding of what it is. But it's a truly fascinating field. Especially when you think of things like molecular pathology, which is where medical diagnostics is going, especially with hematologic and solid organ malignancies. So we're only going to be playing a bigger and bigger role in patient care moving forward. So if you think you might be interested, ask your friendly local area pathologist, or, get online and Google it out and find out more and read about it. And there's so many different ways that you can get involved. We're always working on projects. So I just finished a case report with a medical student who I think is going into surgery. We have college students, master's level grad students involved in projects. So, it's easy to start to build your resume. But be curious, ask questions, and take that initiative, because it's a great field to be in, and a lot of us, I can't speak for everyone, are super friendly and always really excited. I don't know what the exact percentage across the country of people of sort of graduating medical students going into pathology, but it's I think in my own class of 205 students, there were 3 of us. So it's around like 1, 2, couple percent. So, and there's a lot of really smart people who end up transferring after going into other things. So just seek us out.
All right, there you have it. Again, Dr. Elizabeth Morency, who's been out of training now for 5 years on her journey into cytopathology, talking about everything that she likes, doesn't like, her kind of recommendations for the rest of you who aren't going into pathology, your primary care providers out there, with some information to hopefully make your jobs better, her job better, and your patient's life better. If you got a lot of great value out of this podcast today, I would recommend you share it with a friend. I would love for you to share this with your classmate, with your advisors, with your medical school, whoever you can share this with. I would appreciate it. The more listeners we have, the more lives we can affect. And that is my goal here at MedEd Media. I hope you have a great week. We'll see you next time here on Specialty Stories.
This is MedEd Media.